Great. Well, thank you all for the opportunity to speak with you today. I'm happy to talk with this forum of people and hope that we can have a great discussion later, but thank you for joining and tuning in today. So I have no financial disclosures to report or conflicts of interest. However, I will say that discussing the background of what's new in perinatal marijuana use in the time that we have is quite daunting. So I'm trying to highlight some of the very important work going on in this area and address some of the existing controversies and provides a little bit of guidance. So what I hope to share with you today in this short amount of time is that we have a lot of challenges with studying the effects of perinatal marijuana use. So today I'm going to describe some of the public health concerns in our current era of increasing potency. We're going to describe the challenges with modes of consumption, the complexity of the metabolism, and the difficulty of quantifying exposure across pregnancy and postnatally, and how that affects research interpretation. I'll review some of the literature regarding the effects of perinatal marijuana exposure, and more importantly, evaluate some of the current data regarding duration of marijuana expression in breast milk and some challenges with that guidance, which I know is something that's affecting many of us on a near day-to-day basis. So I don't think it's a surprise to anybody here on this call living in Colorado that legalization of both recreational and medical marijuana is continuing to increase across the United States. So this map is after the election in 2019, or our last election, where nearly 2/3 of us are living in a state with legalized marijuana. Now, we have 15 states plus Washington, D.C. now have legalized recreational marijuana, and 31 states have legal medical marijuana. However, there's variability regarding laws against possession or distribution, and in 6 states, it's still fully illegal. Those are the great ones that are highlighted there, certainly our neighbors to the north. And to note, Canada legalized recreational marijuana in 2019, and they have a very vigorous national campaign regarding monitoring of health effects and public education, and I'll touch on that a little bit later. So the challenge is that in a culture of legalization, the public perception is safety, especially when dispensaries are frequently seen demonstrated by some of these images here, which we've all probably seen, which market toward the natural or healthy options and even a purported clinical endocannabinoid deficiency syndrome. But for some people, marijuana is a panacea to treat numerous medical disorders. And this messaging further confuses the public understanding of the uses of medical marijuana versus recreational use, and also the medical community's understanding of which products have demonstrated efficacy or safety. But what we can anticipate is that with increased legalization, there will be increased use. And this leads us to be concerned from a public health perspective when we think about the implications of more widespread use. If we hearken back to a time when other substances, namely tobacco and alcohol, which are legal, were thought to be safe and even encouraged during pregnancy, with advertisements such as this posing the question of which cigarettes do you smoke, doctor? Or in this Winston commercial on the left-hand side, people are always telling me that smoking causes low birth weight. Talk about a win-win-win, an easy labor, a slim baby, and the full flavor of Winston's. So while these images seem outrageous now, it's worth noting that perhaps exercising caution for vulnerable populations like pregnant women and adolescents makes sense. But we also have to recognize that public health endeavors and changing people's perceptions takes time and even decades. So we'll now review some of that data on public health and marijuana prevalence and the effects on parenting. So in brief, marijuana is the most commonly used previously illicit drug in pregnancy, with an estimated prevalence ranging from 3 to 30%, depending on the method used to define exposure in the population you're looking at. We know it crosses the placenta, and currently ACOG, the AAP, and the Academy of Breastfeeding Medicine do not recommend marijuana use during pregnancy or with breastfeeding. Delta-9 tetrahydrocannabinol, or THC, is highly lipophilic, and it's the psychoactive component of the marijuana plant, and it's known to concentrate in breast milk. And the potency of THC in marijuana products has increased significantly since the 1980s, when the first longitudinal studies of perinatal marijuana effects were initiated. However, identifying THC exposure is challenging owing to its complex metabolism, where metabolites can be detected in urine for weeks after last use. And additionally, urine tests may relay poor information regarding the frequency or patterns of marijuana use. And because of these issues, most research Or most research has been limited by relying on self-report to define exposure. So along with legalization,
sorry to interrupt.
Yeah, go ahead.
Can everyone please make sure to mute themselves? We know that you have busy lives, but we're getting a little bit of background noise, so thank you.
So along with legalization, the perception of safety may be strengthened by advice from dispensaries, particularly if consumers seek advice from them. So this is a cross-sectional study done here in Colorado from 2018 of 400 marijuana dispensaries, where they were evaluated regarding advice for symptoms of first trimester morning sickness. And they utilized a mystery caller approach with a standardized script, which is shown here on the right, that's asking for recommendations to treat nausea. So of the 400 dispensaries contacted, 277 or 69% recommended cannabis use for first trimester morning sickness. Interestingly, 83% of the medical dispensaries recommended cannabis compared to 60% of the retail dispensaries. And these recommendations were predominantly based on personal opinion, where 36% overall said it was safe to use in pregnancy and 56% were unsure. And ultimately, 82% recommended discussing it with a healthcare provider, but only 32% of them made this recommendation without being prompted by the caller at all. Now, interestingly, the authors repeated the study design in Canada in 2020, 1 year after legalization there, and found that 93% of the dispensaries recommended against use during pregnancy in Canada. And recall that I mentioned that their rigorous public health education campaign was somewhat of a different rollout than what we have here in the United States with variations by state. Jarlinski published a research letter in 2017 using data from the National Surveys of Drug Use and Health from 2005 to 2012 on surveys of pregnant women who admitted to marijuana use in the past month. And those reported no risk of harm rose from 26% in 2005 to 65% in 2012. And additionally, women are unlikely to obtain information from their healthcare provider, instead using advice from friends, family, and internet searches. I think that's probably reflective of that increasing legalization. A recent survey of over 1,000 pregnant women regarding knowledge and attitudes of marijuana use in pregnancy found low knowledge regarding potential risks during pregnancy. And astonishingly, more than 90% report that they would use during pregnancy if it were legal. However, this public perception of safety might also be somewhat due to healthcare providers. Holland found that among 486 OB patient interactions, that only 48% of providers responded to a disclosure of marijuana use. And Bulgaria published a survey of lactation specialists from 2015 and their recommendations for breastfeeding with known marijuana use, where 44% of LCs would recommend breastfeeding, 41% would recommend breastfeeding based on the quantity of use, and 15% wouldn't recommend it at all. Now, another public health concern, along with perceptions of safety with legalization, has to do with potency. And Al-Soli published this data in 2016 about the potency of seized marijuana from the DEA, which has increased at least 5-fold since 2000. So this graph here depicts the average potency or percent THC content marijuana substances that are seized by the DEA on the y-axis and years on the x-axis. And we can see this steady increase in potency from the early 1980s, noting about a 4% THC content when two of the large longitudinal studies, the maternal health practices and child development study and the Ottawa prenatal prospective study were started. But I've also added on the far right additional research from CDPHE regarding the average percent THC content in products available to consumers here, where we see that joints or blunts rising to 20 to 30% in 2019, and the development of butane hash oil, also called like butter or shatter, which is basically like freebase THC content, freebase, which is vaporized and then inhaled, and it has a THC content of anywhere from 60 to 90%. Those are the high concentrated THC products. But what we are concerned about is this rising potency is seen in the United States with increasing legalization. It's also being demonstrated in Europe and Canada, but to a little bit of a lesser degree as far as the higher potency products. Sorry about my child tussling in the background. So the three primary prospective longitudinal studies of marijuana exposure that I talked about earlier are listed here, with the Ottawa study, and then the maternal health practices and child development study, and the Generation R study. Started in 1978, 1982, and 2002, respectively, as you can see this. And they all studied these infants into childhood and adolescence. And you can see the cohorts are somewhat diverse here in their composition. And that's part of the challenge in interpreting the data coming from these cohorts, as well as loss to follow-up. However, multiple studies published from these do note some concerning outcomes of neurodevelopment, keeping in mind that these results are when marijuana potency was about 4%. So we're like 5 or 6 times or more higher now. And the concern is that prenatal THC exposure causes brain miswiring. It can disrupt the synaptic connectivity underpinning memory, cognition, and executive function, leading to permanent neurobehavioral and cognitive impairments. So in infancy, this might be very subtle. For example, we don't see typically really significant newborn withdrawal symptoms. But later in school-age children and adolescents, there are several neurodevelopmental impacts of attention, memory, and early development of depression and anxiety. Now, I agree, there's certainly many confounding factors in these cohorts. It's very challenging to disentangle, such as socioeconomic status, concomitant exposures. However, it raises concern about the safety of perinatal marijuana use in long-term neurodevelopment, particularly in today's much higher potency environment. I want to touch on 2 recent meta-analyses. I guess I say recent, tongue-in-cheek, it's now several years ago. But if you were to do your own literature search and say, hey, I want to check these 2 meta-analyses, which we usually think of as culminating data together, these 2 studies were interesting, published just months apart in 2016. And they were really attempting to distill marijuana use in pregnancy and perinatal outcomes. So just looking at what happens with moms as well as with those newborns in that sort of perinatal period. And they provide slightly conflicting conclusions based on their methodology. So the first one is Gunn et al., and it included 24 studies with a meta-analysis on variables if more than 3 studies included that defined variable. And marijuana exposure was by self-report or any biological measure found in the study of marijuana use. And they found an increased odds of low birth weight and NICU admission in those 24 studies overall. However, Connor et al. Focused specifically on low birth weight and preterm birth and included 31 studies in their analysis. And in their unadjusted data, found an increased risk of low birth weight and preterm birth with marijuana use. But then they adjusted for tobacco use, and this effect was no longer seen, but it was only on a handful of studies. Not all 31 reported on that. So it was only like essentially 4 studies. And so furthermore, in Connor's conclusion statements, they said that all the adverse neonatal effects from marijuana use were attributed to concomitant tobacco exposure. So we should have more efforts on addressing tobacco cessation than marijuana. But remember, these papers address studies from the past 3 decades where maternal and neonatal outcomes continue to be conflicting. And keep in mind that the methods of defining exposure were predominantly by self-report, which might underestimate use. And maybe using more current methods of defining marijuana exposure in our current era might be better in trying to rigorously determine the definition of exposure with biological sampling and really help us understand any association of prenatal marijuana use and early pregnancy outcomes or later outcomes in childhood. So the following studies were published following those 2 meta-analyses, and I just wanted to touch on them really quick in case it's in your literature review and you're wondering about this. So Daughters Katz performed a secondary analysis from a multi-center RCT of the BEAM study and beneficial effects of amnityl magnesium. And they found no difference in a composite outcome of neonatal morbidities or of early childhood outcomes of cerebral palsy. And again, look at the time frame of this. This again is in the early 2000s. And in a sub-analysis of infants less than 28 weeks gestational age, there was also no difference in outcome. However, another secondary analysis published by Metz et al. Of the Stillbirth Collaborative Research Network and using the control mother-infant diehads defined marijuana exposure by self-report, but also had THC quantification by an umbilical cord homogenate testing, or kind of like a cord tox, and found 3 times increased risk of a composite outcome of neonatal morbidity among infants whose mothers had used marijuana in pregnancy. And then in the literature review just published last fall, of 45 studies, they didn't perform a formal meta-analysis by TORS that found no association between prenatal cannabis exposure and cognitive outcomes. However, again, this wasn't a formal analysis. This was just kind of a discussion of data. So where do all these conflicting studies leave us? It's really complicated. So I look at this as the heterogeneity of outcomes on perinatal marijuana exposure is really due to incomplete and inaccurate assessment of exposure. So help me in my research, I kind of developed this flow diagram as a visual representation of the challenges we face. And so moving left to right, we have the mother-infant dyad throughout the trimesters of pregnancy, and then with delivery, that lightning bolt there, and then the newborn period coupled with lactation, and assessments of neurodevelopment in either the neonatal, childhood, or adolescent periods. Now, understandably, there are lots of confounding factors along the way, shown at the bottom of this slide, such as concomitant exposures, tobacco, alcohol, opioids, methamphetamine, or others. Maternal mental health concerns, anxiety, depression, PTSD, postpartum depression, and how that might interfere with maternal-infant bonding and early childhood development. Either diagnosis and maternal health issues that could be either diagnosed or treated or under-recognized and self-treated. And then the social determinants of health, race, ethnicity, socioeconomic status, and education, which also may affect the measurement of neurodevelopmental outcomes. And then we also have to consider how these are measured. Are they validated testing for cognitive ability and behavior or psychiatric diagnoses? We have to also then think about pediatric use in adolescents. And then critically, what's the availability of long-term follow-up in these cohorts? So in addition to this complex framework, we have to add in maternal and fetal factors, such as maternal past medical history, nutrition, BMI, and individual pharmacogenomics, which might affect maternal metabolism. THC effects on placentation and embryogenesis, where this research is limited because studies on congenital malformations are not limited to exposure in the first trimester, we take all comers. And during the second trimester, there's the development of the endocannabinoid system with critical development of axons and proliferation of and neuronal migration, synaptogenesis, and we think about CNS neurotransmitters. And then at delivery may be affected by vast metabolic changes, transition from placental circulation and the possibility of preterm labor, hypertensive diseases of pregnancy, and stillbirth risks. For newborns, we have to consider prematurity, the IUGR baby or SGA status that might affect neurodevelopment, but also the unknowns of enteral metabolism when considering lactation effects, such as milk fat content, maternal BMI, hepatic metabolism, and whether mothers have abstained from marijuana after delivery or if they have actually increased their use now that they aren't pregnant anymore. Now, stepping back from this complicated longitudinal diagram of this perinatal experience, we then have to consider how and when do we quantify marijuana exposure? Do we rely, sort of grudgingly on self-report alone? Are we able to do biological sampling? What was the mode of mother's marijuana consumption, or is it secondhand self-exposure? What was the potency of the product that she's using? The frequency, and then the timing throughout pregnancy. Was it more during the last trimester or variations throughout? And then what about the biological samples that we use to ascertain exposure? What's the laboratory method? So what I hope that you can see is that the challenges depicted here demonstrate that the heterogeneity of outcomes that we see in the literature of perinatal marijuana exposure is due to this incomplete and inaccurate assessment of exposure. And it's just really, really complicated and why it's not straightforward. So we're going to switch gears now, and we're going to fill in some basics of the endocannabinoid system, which I just sort of briefly talked about, and cannabinoid metabolism, because I think it's important to our discussion. So endocannabinoids and their receptors, CB1 and CB2, are found throughout the body with a variety of physiologic responses when they're activated, though they sort of trend toward homeostasis. They're the opposite of the flight or flight response. And the predominant endogenous endocannabinoids that our own bodies make are anandamide and 2-AG, 2-arachidonoglycerol. And they activate CB1 receptors throughout the brain, which some of these receptors are shown to the right. And you can see they're distributed all over in different parts of the brain with different functions. Now, phytocannabinoids are those that are found in the cannabis plant itself. When we commonly think of THC, which is a psychoactive and highly lipophilic compound in cannabis, and then we also have CBD, which is the second most common cannabinoid in the plant and in hemp. And then there's also over 200 different terpenes that have varying quantities depending on the strain, and they probably have likely different physiologic effects. And these exogenous cannabinoids can stimulate both CB1 and CB2 receptors, among others. And it's really important in understanding that the complex composition of those phytocannabinoids, different strains, might complicate studying or describing the physiological effects of these products available to consumers. So setting aside the complexity of the endocannabinoid system, there's other inherent challenges when defining exposure and might affect our study design and interpretation. So most clinical studies, as I said, they use self-report. They might use a urine toxicology, but there's a lot of difficulties in quantifying marijuana consumption. First of all, there's several modes available, such as smoking, vaping, edibles, and then that highly concentrated wax, chatter, or butter product. And then there's variations in potency among these products too, not to mention how that's measured. Is it reliable? And are patients even aware of what that potency is? And then there's variations in frequency. How many episodes per week or per day? How do you define it? Is it smoking one full joint or a bowl or a number of gummies that somebody consumes? What about the frequency over time, especially when you're talking about long-term exposure, like during pregnancy and lactation? So defining use of cannabis is not the same as with alcohol, where we understand proof or measured content of ethanol, and we sort of understand variations in wine, beer, or hard liquor. And it's something that's standardized and clearly very regulated. It's not so with the cannabis industry. So in comparison to alcohol, cannabinoid metabolism is much more complex. And since THC is lipophilic, it doesn't follow first order kinetics like alcohol. It has this massive volume of distribution because it just doesn't stay in one compartment. So with whatever mode of consumption that there is, there's variable absorption into the circulation and variable timing of the onset effects. And then once in the circulation, THC is rapidly metabolized by the liver and then also transferred rapidly into the fatty tissue storage due to its highly lipophilic nature. And then that volume of distribution might be variable based on someone's BMI. And then some of THC is metabolized when it goes through that first pass metabolism in the liver to its water soluble form and can be excreted in the urine or in the feces. But what we see is that there's a biphasic pattern of metabolism with an initial rapid first pass, followed by slow excretion from the fatty tissues back into the circulation. And it's presumably what occurs with chronic or heavy use, and the reason why we see detection of urine metabolites even weeks after last use in somebody who might be a chronic user. And this leads to challenges in quantification of exposure. But in perinatal use, we know that THC crosses the placenta, it crosses the fetal blood-brain barrier, and as we'll discuss a little bit later, it's excreted in the breast milk and accumulates there. So beyond self-report, there are biological sources with urine, meconium, and recently umbilical cord homogenate becoming available for detection. And methods of quantification, including enzyme immunoassays or standard sort of urine drug screens, which don't detect sort of acute marijuana use, also have metabolites that can be detected in urine for weeks after last use in chronic users. But ELISAs, those urine drug tests, are not valid for testing cannabinoids in milk because they're lipophilic and bound. Now, the current ideal method for cannabinoid testing and ultra-high performance liquid chromatography coupled with tandem mass spectrometry with limits of detection 10 to 100 times more sensitive than previous methods. But that's usually what's used for like research methodology, not for typical clinical hospital specimens. So now I'll talk a little bit about some research demonstrating why it's really important to couple that biological sampling with self-report for methods of exposure. So Rodriguez and colleagues performed a retrospective study of over 1,200 adolescent clinic patients here in Colorado using universal urine toxicology testing or self-report for defining marijuana exposure and measured the association with a composite outcome of spontaneous preterm birth, hypertensive disease of pregnancy, stillbirth, and SGA. And in this cohort, they found that 17% of these moms were using marijuana, 5% by self-report alone, 65% by urine toxicology alone, and 29% by both. And after adjusting for race, ethnicity, and tobacco use, the odds of that composite outcome by marijuana use defined by self-report or by UTOX was 1.5. However, when only relying on self-report alone, the adjusted odds were no longer significant. You can see that the confidence interval crosses 1, so that's where we say we're just not as confident. Furthermore, if more than one urine toxicology test was positive, the odds of the composite outcome was 3.75. So almost a 4 times increased risk of that composite outcome if moms had a positive UTOX throughout pregnancy, indicating that that's a concern with prolonged or persistent use. Another example of discrepancy between self-report and biological sampling is shown here by Metz et al. Some of you may know Troy Metz was a maternal fetal medicine researcher here, is now in University of Utah, but she's done a lot of perinatal marijuana research. So this was one of her 2 studies that I'm going to discuss. It's a cross-sectional study of women delivering at 2 urban hospitals here in Colorado. And they compared self-reported marijuana use by a survey, which was anonymously administered and then correlated with the biological sampling of marijuana metabolite in the umbilical cord homogenate. So the cord segments were assayed for THCA using liquid chromatography tandem mass spec, as I mentioned, where the limit of detection and the limit of quantification are shown in the rows in this table below. So on survey, only 6% of women reported use in the last 30 days. But umbilical cord testing showed that 10% had a THCA level above the limit of quantification, and 22% had a THC level above the limit of detection. And this demonstrates sort of the importance of biological sampling in estimating use among our mothers. Now, in another study from Metz, is a little bit of a different design. This was a prospective observational study with the objective of really correlating that prenatal self-report of marijuana use with serum, urine, and umbilical cord assays of those marijuana metabolites throughout pregnancy. And so in this one, 46 women were identified in the first trimester with known marijuana use, were approached for the study, said, would you like to enroll? We're going to study you for 4 visits here from your enrollment in the first trimester, and then 2 more pregnancy study visits, and then again at delivery. And we're also going to collect serum, urine, and sample of the umbilical cord segment for this research study. So they enrolled 46 women, and the results found that a predominance of women on survey were using marijuana to relieve nausea and for pain and anxiety, which really persisted through delivery. And note that 44% of those women were still using at the time of delivery. And while they found that there was a strong correlation between self-reported use of marijuana in the previous 30 days at the time of delivery with the umbilical cord metabolites, there was less correlation with self-report on the earlier study visits. Now, self-report in this cohort was, strong, probably due to legalization. These women felt open and honest to share this with their healthcare providers, but it also demonstrates a concern over women continuing to use through pregnancy despite being counseled for abstention. And I think the importance of this study is really kind of will be used as a hallmark for quantification of marijuana metabolites and correlating that with self-report. And while dosing amounts of how much marijuana women were using still needs to be evaluated, it is valuable when we think about designing future studies to correlate marijuana exposure to later outcomes, that really quantification by biological analysis is important. So what about measuring cannabinoid excretion in breast milk? So as I move forward, recognize that what I'm talking about right now is really just talking about pharmacokinetics and just what we can detect. It's not talking about outcomes. And remember that initial really busy slide about the difficulty to isolate sort of the effects of prenatal marijuana use throughout pregnancy, through the postnatal phase, through lactation. We can evaluate THC excretion in the breast milk to determine sort of the concentration and what babies might be exposed to. So I'm just going to highlight 4 studies that have been published on this subject just in the recent few years. And before that, we didn't have anything prior to like 1982. So the first one is by Baker and Hale, and this was a pilot pharmacokinetic study of THC in breast milk following cannabis inhalation. So 8 women were anonymously enrolled at 2 to 5 months postpartum, and they were recruited from social media websites here in Colorado, from like Badass Breastfeeders in Colorado. And then it was conducted anonymously from Texas. That's where this was initiated. So women completed a survey of history of use, and they were directed to a designated dispensary to purchase Presidential Kush strain of marijuana for inhalation, which was estimated to be a quantity of 0.1 grams of with THC content of about 23%. So we have somewhat of a biased population here because they're probably already likely marijuana users. And women were instructed to have 24 hours of abstention from cannabis prior to expressing a baseline sample of breast milk, and then they performed self-directed consumption of the product and then provided express breast milk at 20 minutes, 1, 2, and 4 hours after inhalation. And then they were instructed to freeze their samples and then mail them to the research team in Texas. But it was all done anonymously. We don't know if they used the product. We don't know what samples they actually sent. So there's some flaws in this study and a little bit of concern. I go forward too many. Sorry about that. So this table demonstrates the initial survey results of the reported answers from these 8 moms. And note that 3 of them, where it says ND, did not disclose the frequency of their use per week or their daily cannabis ingestion or mode. But they did find that THC was detected in breast milk in all samples beyond the baseline of time 0, and no other cannabinoids were found in the breast milk, which is important to note, is primarily THC. And the authors cite an estimated mean infant relative dose was 2.5% of the mother's ingested dose, with a range anywhere from 0.4 to 8.5%, essentially, of what mom took. And then the graph on the left demonstrates the THC concentration in expressed breast milk in nanograms per ml for all 8 women, showing a peak in THC concentration at 1 hour following inhalation, with a broad range of measured THC concentration. That's what these error bars represent, is the range of THC. So you can see anywhere from it's under 100 to up to 215. Now the table on the right provides the pharmacokinetic calculations of THC in breast milk for those 4 hours. And what I really want you to note is that wide variability, like I said, of THC excretion anywhere from 33 nanograms to 744. And that wide variability may be attributed to variations in women's patterns of marijuana use, their own inherent metabolism, possibly their maternal BMI, and the composition of their breast milk. So the second study, published by Bertrand and colleagues from San Diego, was a cross-sectional study of breast milk from 50 women with a self-reported marijuana use. They have a big donor milk research repository there, and they found that 63% of the samples were positive for THC, with a median of 9.47 nanograms per ml, but again, with a wide range of concentration. You can see this here, anywhere from 1 to 323. And then they performed an analysis using the number of hours since last reported use by that survey and the frequency of use, and they predicted the log THC concentration shown in this graph over here. I don't know if you guys can see my cursor, sorry, over here. But the number of hours since last reported use and frequency of use predicted the log concentration. So we have the log concentration on the y-axis, and on the x-axis is time. And what they found was a significant association between THC concentrations and hours since last use, which corresponded to about a 3% reduction in THC per hour, but they estimated a half-life of about 27 hours, but the longest duration of excretion they found was about 6 days. And the authors speculated again that the range of THC concentration and that variability in half-life estimates was probably due to the fat content of the milk, frequency of marijuana use, and an individual factors. And then this past January, researchers at the University of Utah published their prospective study in pediatric research, recruiting sort of some volunteer postpartum women with a history of marijuana use. So they found 20 women who were recruited with study visits at 2 weeks postpartum and 2 months. And they had surveys of use and then provided plasma and milk samples for cannabinoid analysis. Now, the median past 7-day instances of cannabis use at visit 1, so this is 2 weeks postpartum, was 17, with an interquartile range of 6 to 29. But then at visit 2, this increased to 23 times in the last 7 days, ranging anywhere from 15 to 45 times. And the breast milk THC concentration for visit 1 was about 27 nanograms per ml. And again, a really wide range of that THC excretion. And then this also increased by 30 nanograms per ml for visit 2, again, with that wide range noted there in parentheses. So the graph on the right demonstrates the increase in cannabis use between visits and, as expected, an associated increase in THC excretion in breast milk as well. And then we performed a study in Colorado, also published this past spring. It was an observational pharmacokinetic study of THC in breast milk following maternal marijuana cessation at delivery. And so we collected surveys of use and milk and plasma and urine for 6 weeks postpartum, multiple samples that we collected. We screened 394 women, but only were able to enroll 25, and the majority of whom used marijuana in pregnancy more than twice per week. So only 12 of our women had evidence of abstention, and of those, 7 completed all 6 weeks of the study. And we found that the median sort of milk plasma ratio was 6:1, so it's concentrated in the milk, and among women who abstained from marijuana use postnatally. Now, this slide demonstrates the patterns of marijuana excretion in the milk and plasma of several different study patients. This wasn't in the paper, but I just want to share it with you because I think it's visually representative of the variation in how these moms progress. So we have moms who not only abstained, but ones who continued use. So the THC concentrations are on the y-axis on a log scale, with time in weeks on the x-axis for the study duration. And then the black lines represent the THC in milk, and the gray is the plasma metabolite, that carboxy-THC. So graph A shows sort of our model mom who abstained for the study duration. That's in the upper left-hand corner. But graphs B, C, and D demonstrate mothers with failed abstention from marijuana during the study, noting that sort of wide variability of THC concentrations in milk from sort of less than 5 nanograms per ml to greater than 100 nanograms per ml. And this figure represents the breast milk concentrations among the 7 women who abstained and who completed the most study weeks. So the y-axis represents breast milk THC concentrations in nanograms per ml, and the x-axis represents time and days of the study. And based on the continual decline of THC in milk among these patients, the pharmacokinetic modeling we applied of those 7 women, we estimated the THC terminal half-life to be about 17 days, so you double that, so excretion would be greater than 6 weeks among women who abstained from marijuana use after delivery. Now, the challenge is that we have different results from 4 different studies of saying how long is THC excreted in milk so we can limit the postnatal exposure of marijuana to these babies. That's the big burning question. So I've compiled this into a table of all these studies describing that excretion. And what I want you to see is that there's variability among those study designs, as I tried to sort of describe in this presentation, in regards to the number of patients, how many weeks they were postpartum, the number of samples which were analyzed over there in the second to the last column. But what I want to note is that all studies really report wide variations in the patterns and frequency of maternal marijuana use, which might contribute to that variation in milk THC concentrations. In addition to, there's probably variations in the potency of the products they're using and individual metabolism, BMI, and milk composition. But what this also demonstrates that self-reported marijuana use cannot be used to predict or quantify the amount of THC in breast milk at delivery. And we really don't have good tools to be able to say how long that's excreted. And what we do see is that abstention from marijuana is really difficult. So our national guidelines for breastfeeding with marijuana exposure from the AAP, ACOG, and Academy of Breastfeeding Medicine are shown here. I'm sure we all know this and kind of struggle with this. There's slight variations between their wording and their language, which we can discuss later, but the AAP policy from 2012 says it's, should be discouraged. It's been updated in the last few years. Previously they said it was contraindicated, now they say it should be discouraged. And ACOG specifically states that women should not use or be given medical marijuana during pregnancy and to universally screen for SUDs in pregnancy. It says there's insufficient evidence for the effects of marijuana in nursing and the nursing infant, therefore they recommend it should be discouraged. And the Academy of Breastfeeding Medicine urges caution as well, but they say carefully weigh the risk of initiation and continuation while using marijuana with how much moms use. And I think that's really a challenge because then that places this on the provider to make that determination of what's too much. So So really it's just all over the map, which I know everybody in this audience is frustrated by. Sorry, I have a little visitor into the room here. I'm not going to be able to answer that question until I'm finished. Moving forward, where does that leave us? So a few conclusions about all these things that I've been talking about today. That we know that the prevalence of THC use during pregnancy is increasing, possibly due to increased perceptions of safety. That biological quantification of THC exposure, rather than self-report, are really imperative to accurately assess any outcomes or effects of marijuana use for research purposes, or even trying to determine associations of harm. That THC metabolism and pharmacokinetics remain complex, appearing to have a biphasic expression in breast milk, and this excretion may persist for weeks after last use and may be affected by BMI, frequency of use, and modes of use, and potency. And finally, really, really importantly, that pharmacokinetic data that I just showed you in breast milk is not intended to assess safety. That's really just pharmacology. And we need more and more research in this area to determine. So what are some of our future research directions? How can we ascertain the THC loading dose or quantify exposure during pregnancy and postnatally? This is something we're actively working on campus here. How can we measure and assess what patients are using, and how can we validate that potency? Because a lot of times people don't know, because that's really important in trying to correlate with metabolism and excretion in whatever biological sample you have. And what are the excretion patterns in moms who use cannabis frequently? Certainly in breast milk, that's an unknown. What is the infant metabolism following ingestion or secondhand smoke exposure? This was something we really tried to study, but the IRB prohibits some of this testing or analysis on infants, so that's a big challenge. What are the effective methods to promote cessation early in pregnancy, and understand more about why moms are using, and have better tools or supports in place to help them with abstention? And how can we be compassionate caregivers and really try to say, it seems like you're struggling, how can we help you in a better way, and really partner with moms? And certainly also identify if there's underlying mental health issues that are contributing to their need to use. How can we address those things? We know these are so interrelated. And then further, from a physiology standpoint, what are the differential neurologic effects of THC exposure throughout pregnancy, separated from that postnatal exposure? Are there differential effects based on the gestational age? And it goes back to that really complex slide that I showed you guys before. And it really begs the next question: is there any safe dose or amount of marijuana to use during breastfeeding? Which we don't have that answer. So I think right now our answer should be caution. So when we think about infants who are already exposed prenatally to unknown amounts of marijuana, we say, do the benefits of continued breastfeeding with an uncertain amount of continued THC exposure outweigh the benefits of no mother's milk, but decreased exposure of THC? And what about those highly vulnerable patients, such as preterm infants? Are their brains more, susceptible? Is that more concerning? And if we prioritize breastfeeding, how do we counsel mothers about the amount of marijuana to use when the data shows such wide variability in THC excretion in breast milk? Is there any safe dose or amount of marijuana to use during breastfeeding? And I just think that we don't have that answer. I think we have to say, no, we should be exercising caution. So in the meantime, what do we tell families? So again, I want to emphasize, approach this with compassion and support, really trying to partner with mothers and families, that our goal is for a safe and sober caregiver, and that we know that there may be a perception in the community of safety, certainly with legalization, and mothers may be self-medicating for another reason, but we need to clearly emphasize that there are no known benefits of marijuana use in pregnancy, that there's possible risks of marijuana use in pregnancy and lactation, and advise them not to use during these time periods, and that there's no known safe amount of marijuana to use in pregnancy or lactation. So recognizing that we can't design a study to randomize infants to breast milk with known marijuana exposure and long-term, and that certainly the long-term effects take a lot of time in this era of current potency. What can we do right now? So some practical steps that we can do to improve care for mothers and infants is all the reason why people are participating in this AIM initiative, right? We care about these moms and these families. So we can engage with our OB partners and really encourage universal screening as is the point of this group, with validated tools for reproductive age women and in pregnancy for any SUD, like using the 4 Ps, SBIRT and QDIT, for the cannabis use disorder intake test, and discuss early on in pregnancy what we want to do to promote safe breastfeeding, because it really should happen prior to the delivery hospitalization. It's really too late at that point. Not too late, but it's just so much more difficult. We know that after a baby is born, it's stressful, it's hard, and really expecting our moms to stop using a substance they've been using to cope or to treat many symptoms would be really, really difficult. We can work towards assisting mothers with abstinence early in pregnancy, like we do with tobacco and alcohol, and explore the reasons why they use, with a heightened awareness of the possible mental health disorders underlying sometimes this use. And then I think we need to be consistent with the current guidelines. The AAP, ACOG, and the Academy of Breastfeeding Medicine advise women not to use during pregnancy and breastfeeding. And I think when we should be consistent with that messaging. There's no data that says that it's safe. And so I think we, to be consistent and help develop trust with our families, we want to make sure that we say, hey, the data is limited and we need more data. And there's limits to the evidence of that data, but we don't want these kids to then suddenly, when they're older, have more issues with cognitive development and certainly increased risk of mental health issues. So I think there's enough data to show concern that we should be cautious. So here are some guidelines for providers. I know a lot of people in this forum probably already have a lot of this information, particularly for SBIRT, but this is just some extra information specific to marijuana use. Okay. Just like to thank you guys for your attention. I have my research team on the left, Maya Bunick, and I normally do a little bit of a talk together. This is sort of my my research discussion, but there's so many people that help us do this work, and many mentors across the country also as well, from pharmacologists, and people do a lot of marijuana research. So I really have to say that I am very thankful for their support and guidance and mentorship. Thank you.
Thank you, Dr. Rymore. Everyone, we can open it up to questions and discussion. So whatever thoughts you had come up or questions, please come off mute and share them. Or if you would rather do it in the chat, that's great too.
I have a question. What would you suggest if there's a woman who's using marijuana and delivers her baby? And in our hospital, we have them pump and dump, or we advise not to breastfeed. But let's say they're really motivated to abstain and they want to abstain, but they still want to breastfeed. Currently, we're telling them to pump and dump for 30 days. What do you think about that?
Well, our data would show that they're still expressing THC, that it's really hard to determine whether or not it's a small amount or a high amount. I think that your conservative pump and dump for 30 days is reasonable. I think if she really truly is abstaining, and by that time you likely don't have as much contact with her unless she's in the NICU, right?
Right.
So I think that it's really, really hard, because we really want to support these moms who are pumping and pumping and pumping. And it's like every time they pour that liquid gold down the sink, it's like probably just has to be heartbreaking, right? And that's why I say we have to have this conversation early in pregnancy. But I think the data would support what you're saying to her. I know I've just been on this last week. There's the International Research Society for human milk and lactation is going on this week in Sweden right now. There's so many benefits to breast milk. I understand that, but I think there's also concern when we see these signals of, neurodevelopmental impact. And I think limiting that exposure is important. It's more concentrated, it's a higher dose. And the data that we have, it's hard to know what products she's using. So I would stay strong in your recommendations. We don't have specific national guidelines in saying this is how long you should pump and dump, but I think a month is reasonable. I feel confident in your recommendations.
Okay, well, thank you.
Hi, Erica, it's Jamie. I'm just curious, and maybe others could chat this in. Are other hospitals, I saw a number of hospitals represented on this call. Do you have protocols in place about this? Is it something you're still discussing? Just curious what's happening across the state. And thank you, Cindy, for sharing what your hospital is doing. I'm guessing others have something in place or have had conversations. I'm curious what that might be. Maybe an easier question. Does any hospital have a protocol in place about breastfeeding and marijuana? Okay, Mick, thank you. No real protocols in place for your hospital. Wondering if that might be the majority.
I think a lot of places might have, the hospitals that I work in anyway, or have interfaced with, have variable protocols about this. And I think that's what's really hard. Again, it's between those three organizations saying we really discourage this, or Academy of Breastfeeding Medicine says it's based on how much mom's using. I think what I'm trying to highlight is, in the data that we see, is that moms have difficulty with abstention postpartum. There's wide variability of excretion. It might seem, and we don't know, even though those numbers I say, oh, a low amount, we don't know what a low amount means. Just you're looking at a scale and what those repercussions are for later in life. And when you think about somebody, I think many of us on this call have experienced parenthood and know that those first couple of weeks are really hard. And so, right there. So having some compassion about, we know that this is difficult. I think just trying to engage moms and really say, we really know this is hard. We really want to help you quit. We don't really know the best ways to do this, but we really want to share the importance to you. This is more concentrated in the milk than in the plasma. So we know your baby's seeing more of it than if it's in your bloodstream. I think that that's important. We still need a lot more data on how babies metabolize this. It's not the same as for adults. And that data is an unknown. It's a big unknown. To say that it's safe is different. It's just an unknown. And I think just recognizing that. Some hospitals that I work in, we say pump and dump for 2 weeks. In our NICUs, through Children's and University, we say pump and dump for 2 weeks, but we don't have a mechanism in place to have moms provide a urine toxicology test. We have some data that's coming out right now that shows that urine toxicology tests, a negative test doesn't mean absence of THC in breast milk. So it's really, really hard. But I think that's why we need to change the culture and turn this to discussions earlier in pregnancy about this.
Yeah, that's great, Erica. I see Sarah mentioned as well, her hospital has a protocol to pump and dump for 2 weeks, depending on how much is self-reported. So I think you're exactly right. A lot of variation and uncertainty, right? Not much to rely back on the data. Right. So very challenging.
And I think another thing to point out, sort of the highlight, when I think we developed that, hopefully that sort of point of compassion, not like, no, we're going to not ever let you breastfeed your baby, but just saying, hey, we really need to talk about this. This is really important. That's when women tend to be more forthcoming. If you saw the differences in the 2 studies by Metz, by Tori, she saw that women weren't real, the first study was like an anonymous, question of, are you using marijuana? But they found it was really underreported. But when it was enrolling women who felt comfortable to express it to their healthcare providers, there was a lot of correlation with self-report and the biological sampling. So I think it just demonstrates that being really compassionate, really engaging in education for families is important.
Sorry,
Katie. I was just saying, I love that. And I think that's come up on multiple occasions through this collaborative, is the importance of the rapport, the trust, and building the relationship and seeing our patients as partners with our providers. And a few other providers have mentioned that patients welcome conversation and information, but they're scared. And so I think so much of this is in that delivery and that relationship building and having conversations. So I appreciate that you said that, Erica, and sorry to interrupt, Katie. I'll hand it back to you.
Oh, no, that's okay. I was just going to say, I know we've heard from hospitals in the past that some hospitals have protocols where if someone discloses marijuana use, they will not be offered lactation support. And I guess the assumption there is like, well, we don't want to tell you how to do it if you're going to keep, smoking marijuana or whatever. What would your recommendation be surrounding lactation support? Whether the person, like, let's say the person says like, I would like to breastfeed anyway, regardless of whether they plan to abstain or not.
Yeah, that's really hitting the nail on the head. I see like our Ann Baring here is representing our University of Colorado lactation team. And we are going through this very issue right now because it is really hard to provide support for lactation, but say we don't want you to breastfeed because we know that you're using marijuana and you're not stopping. We're trying to work towards coming to a better approach to that scenario. This is some education. This is how we want to breastfeed, but we're really, a lot of moms will do it anyway in the hospital, even though the lactation consultants won't, support that. So it's a challenge. I want to let Ann comment because I know I see you coming off of mute right now because I want to see what you guys are doing.
You're right. It causes a lot of conflict, especially for the nurse at the bedside. You want to make sure, we do have patients that say, yes, I use marijuana, and no, I have no intention of stopping, and yes, I am going to breastfeed my baby. So there's a very big conflict between making sure that the baby is getting nutrition and not supporting the mom's choice to do something that we don't think is the best choice for her baby. The nurses are caught in the middle. We have a really supportive pediatric team who's very frank with the mom and tells them that this is not something that we support. We would rather you pump and dump, yet we do want the baby to leave our facility knowing that they are getting nutrition as well. So you're right, there is no easy answer for this, and the bedside nurse feels very conflicted and caught in the middle.
And that's where I think that sometimes when we talk about, I think on our call yesterday for the EFG group, where we say that, how can we maintain some continuity with these moms after discharge? Because a lot of times we don't ever see them again, right? They're going to go to their pediatrician that may or may not know this stuff because whether or not we put this on the discharge summary. And then also the obstetrical follow-up might not be for another, 6 weeks. And then whether or not they are in a program or who's seeing them. And I see Kaylin here too. So I don't know if Kaylin or Jessica, if you want to comment. I'm putting you on the spot.
No. I'm happy to. You and I have talked about this so much, and I think this is so important. As far as like the follow-up piece, I think, yes, that will continue to be something that for all dyads, we should continue to work on. But I do think this falls a little bit into the work around like plan of safe care. And it seems like one of the most important parts of that is that warm handoff to the follow-up family medicine or pediatrician provider. So that hopefully they can pick up the ball and run with it as far as motivational enhancement towards, I think sometimes because I do see people after discharge and sometimes for long times and multiple pregnancies, don't underestimate the seed you plant. Even though you might feel like, oh, we never see these people again. Like, I think the scenario in which the person goes home and like exclusively breastfeeds for a year using marijuana every day is like super rare, right? I think what the vast majority of the time happens is like what happens for people who don't use marijuana is they try to breastfeed and it's really hard. And many people quit very early anyway. And so I do think planting that seed of like, you can do this, you could make this change for the healthiest outcome for you and your kiddo, right? And then recognizing that really by the time you're seeing somebody at labor and delivery who has been using cannabis through their pregnancy, not that in and of itself is diagnostic, but that person is much more likely to actually have a cannabis use disorder that is going to need substance treatment, right? Because the vast majority of people who use cannabis in a non-substance use disorder, non-addictive way have stopped because they could, right? And so realize that what you're seeing at time of labor and delivery, you're seeing a much smaller percentage of all comers who used cannabis and could have become pregnant. And that throughout each month of pregnancy, more and more people have stopped using. And the people who don't stop using by time of delivery, I would submit, are selecting out for the people who tried to stop on their own and couldn't. And so approaching it in that way and asking, always asking and assuming, I'm trying to work on this in my own practice, is kind of assuming competence, right? Like approaching people, assuming that they can succeed with the proper support and whatever they need, but assuming that that person may have already made several attempts to cut down or quit, and they are feeling shameful that they're at this point. I think that's good just to keep in mind, that really it should be a quick pivot to what have you tried already, what hasn't worked.
I think what you just said, Kaylin, is so valid, and it is expressed in the literature that women have difficulty abstaining postpartum. And I think it is so important because I think we all have become, oh gosh, we see marijuana all the time, everybody's using, it's almost like we're numb to it, and we have bigger fish to fry. And I think a lot of times people leave that, oh, that's just that nugget, oh, she's just a marijuana user, but she doesn't use cocaine and she's not using meth. So we don't take the opportunity to address it. And I think that's a really important point. If you're still using by the time you deliver, and I know we hear this all the time, which is something we have to own, that mothers say, nobody told me this was not good for my baby. Nobody told me that I couldn't breastfeed. They say, and we have to, whether or not that's true or not, we have to recognize that literature has also demonstrated that we as healthcare providers have not always been consistent in our messaging as well. So I think that's another piece I want to bring to the table as we talk about universal screening and how do we provide more passive information for families if providers are not, dealing with it head on. How can we provide that information so they have heard about it, and really make sure that we're consistent. And that I think also goes into the consistency of messaging postpartum as well, with that warm handoff and plans of safe care, because we want to make sure that that message is consistent. And where families, I think, start to not trust us is when there's a lot of variability in messaging.
Absolutely.
This has been an awesome discussion. It's what you were just saying actually is a great segue to what we wanted to talk about next. So we are going to talk about some resources, and then we'll hear from an OB at PSL. Again, just a reminder that we kindly ask that anyone who is not a participating hospital team or a member of our expert faculty group leave the discussion so that we can have really vulnerable and frank conversations about hospital progress. And with that, I'm going to turn it over to our graduate intern, Elena Sayers, to talk about some exciting new resources.
Yeah, so that was actually a really great segue because I have been working on a database of all the resources that focus on substance use disorder, mental health, and substance use disorder treatment in Colorado, specifically targeting the perinatal population. So going on beyond that is like we can reach out to these other services so that for those people who are having like you said, cannabis ongoing addiction, we can reach out to these services. So I'm going to share my screen. Can you all see that okay? Should be the database. Okay, great. Okay, so this is the database that I have made, and it's supposed to be a ongoing and frequently updated database by the Learning Collaborative participants. But basically on the left-hand side, you see all the resources named. We then have phone numbers, point of contact, address, location, And then as you go further to the right, it's some key points that the Learning Collaborative brought up that would be great to know just offhand if that resource offers that. So we have, is childcare available for our perinatal population? This is crucial. If they've just delivered, we want to make sure that they can receive this treatment while not also having to take care of their child at the same time. So if you're looking for a resource like that, you can then sort based on that. Same on transportation. If they provide pregnancy-specific services, that might be more helpful in the prenatal setting rather than at delivery. Female identified patient only treatment, so that you wouldn't be in support groups with your male counterparts. If this is a resource that is for patients or the providers, if they offer telehealth, that's particularly important right now. If it's a residential resource, what languages are available? Predominantly, I wrote down English and Spanish, but there are some that offer a wide range of languages. The insurance accepted, and then any notes that the hospital teams have had. So if they find something out that wasn't initially advertised to them, they could put that there. Finally, I put in a category for good, bad, or excellent experience with this resource so that providers can know in the future if they should use this. So what's really great about this database that providers really brought to my attention when I was making it is that they want to be able to sort by specific categories. And typically they've been handed a pamphlet or something that they can look through that has the resources, but they can't really sort based on what they need. So for this database, I made it so that for each category, you could sort by what you need. So for example, subject matter, you can go to this drop-down menu and then you can clear and then just select what you might need. So you want to find all the resources that have childcare, let's say mental health, and then, or you'd want substance use disorder and mental health. You'd select those, and then it would only give you the ones that offer both of them, which is really great. Are there any questions about that? You can put them in the chat and then I can answer them afterwards. The second resource that I made that will go along with this is, hold on. Sorry, I'm technologically inept. Okay, can you see the guide now? Okay, so this guide is just kind of a quick guide that offers the same information as the database, but if you want it in a different format. So it gives you all the resources. It tells you how to navigate the resource, our recommendations as CPCQC on how you should update the resource frequently, how I created the resource, or the database, I should say, some other helpful ways of thinking. And then I made this like quick little chart so that you can, if you're a visual person, you can just quickly look through them and see what they offer for those key subjects that the Learning Collaborative brought to our attention. So for me, I prefer this way of looking at it because I can be like, oh, like they offer pregnancy specific services highlighted by the pink circle with the belly and the heart. So that's just one way of looking at it. And these resources are available to the Learning Collaborative, and Katie should have put that in the chat.
Indeed, I did. Oh, well, thank you so much to Elena for putting this all together. I know she's been hard at work, you know, trying to support all of the teams with whatever resource gathering that they need. And so this really came together because she identified that it would be helpful for teams to be able to see each other's resources that they've been compiling, especially if you're someone who sometimes sees sometimes sees patients who don't live in the area of your hospital. Maybe they live, you know, somewhere else. And you might be able to find a local resource by using this that another hospital in the cohort has identified. So feel free to ask us any questions about this. We'll send it out, obviously, with the email after this call. And I'm putting Elena's email address in the chat, so you can always reach out to her as well. Thank you, Elena. So with that, we want to turn it over to Dr. Lisa Becker for our last 15 or so minutes of the call. And have Dr. Becker walk us through, what some of the progress has been at Presbyterian St. Luke's. She's agreed to show the team's run charts and sort of tell you about, what happened at each step. And then we wanted to discuss a question or sort of a challenge that Dr. Becker has encountered with patients refusing screenings, and sort of talk as a cohort about other hospitals' experiences with that. And
Are you guys good with it?
Yeah.
Yeah.
Hey there.
hi.
I'm so sorry, guys. I am actually here on the deck today. But I think that we will have time to share our experience and hopefully get to chat about some great ideas. So where our hospital started in terms of drug screening was with 3 basic questions, the answers of which were placed into Meditech. That is a much older medical record system, if you guys are unfamiliar with that. And it was just, do you use tobacco? Do you use any sort of recreational drugs, and do you use any alcohol? Pretty basic, not standardized in any kind of way, and not really anything where we could pull out information, get data sets, kind of direct policy that way. So when I came onto the project, looking through different screening tools, we picked the National Institute of Health TAPS tool, tobacco, alcohol, prescription drug, and substance use tool. And we picked that for a couple of reasons. It screens for use over the last 12 months and has been noted by lots of facilities and lots of wonderful experts giving talks to us. Pregnancy is kind of a special window where many women are more motivated to discontinue use while they're pregnant, but might be at risk of relapsing after they deliver. So if we can catch people screening back the last 12 months and figure out folks who might have stopped with pregnancy but used some sort of substance before, that might be, I thought, a better way to identify folks that might be in need of information or assistance. We rolled out the TAPS tool, and I think overall the nurses have really liked it for a couple of reasons. Kevin Hughes, one of our other experts, committee members, has noted with his research that women are a little more likely to fill out a form than necessarily have more open answers to questions if they're asked verbally and in a way that might seem a little more judgmental. So it's nice for the nurses in that they can have it on the clipboard of forms to fill out like everything else. If the patient has questions about it, then that becomes the piece that we're going to discuss a little bit later. My initial data to the collaborative was our patients screened at all. That was the 100% with Meditech. Then we wanted to do the real screening with a validated tool, and we saw the drop in the percentage of screens that were coming back to us. So I started to wonder about that and looked at who was more reliably turning in the screens and who might be folks for whom that wasn't a step in their intake process. The generalist OBGYNs, it turned out, were maybe a little less likely to document that. And one of the things that I would really like to focus on is getting more information to them about our project, about screening tools, about having information in their office that patients can even pick up off a counter if they're struggling, but they don't yet feel comfortable discussing that with a provider. So I've really learned a lot about that. I also, we have struggled a little bit because we have a lot of new staff, and I'm trying to keep them all informed about, the system, and would like to get feedback from them about what is working best with it for them as well. Some of the forms that came back to us not filled out made me consider our process and whether or not we were approaching this in a way that made patients feel comfortable and safe divulging information. And we did have a few positive screens that those patients per protocol were then informed that they would have a urine drug tox screen, and they declined that, as is their right. I just don't want to miss those people, and I don't want people to feel like our reasons for doing what we're doing would be more for punishment than for healthcare. So we wanted to open up this discussion and talk with all of you to see what your experience has been. We had a really lovely conversation yesterday, and one of our neonatologists, I think, said it perfectly. We would like to use the words that refer to healthcare and to helping a patient and to helping her baby, rather than, implying any sort of legal implications. So with that, all that being said, I'm sorry, that was sort of a wandering path. Would love to hear from other people about things that have worked for them and things that they have changed.
Has anyone else, is anyone else running into this same issue that Lisa's talking about with, patients refusing the screening or refusing the tox test? Chris Tussey asked if you obtain consents before obtaining tox tests.
Yeah, we always do. It's state law, actually. Now, the one thing that we do need to do tox tests for moms. What we don't need a consent for is a cord stat. And in some situations where even with marijuana in our facility, which, might at some point be controversial, cord stats take a segment of the umbilical cord, and there can be evidence of substances in the umbilical cord that might have been from use weeks to months back. So that can be helpful for the neonatologist.
Hey, Lisa, this is Kaylin, or anybody else, but I'm curious about, for the folks who report substance use on the TAPS or anybody else who's using like a screening tool, what additional data do you find you need from reflexing to a request for a urine toxicology for mom?
Well, I don't think we do. There was a comment in our discussion yesterday that if a mom reveals use of one substance, that there's a high incidence of polysubstance use, and that for the pediatricians, if we can identify what substances the baby might have encountered during gestation, that might change their management of the baby. But again, to, use it in a very judicious way and in a respectful way, in a way that says we care about both of you and we'd really like to help. And these are the implications of different sorts of substances for your baby. It just has to be approached in a respectful and more loving way, I think, is the key. Part of the issue with our hospital setting, Health One, of course, is corporate medicine, and anything that's done in one of the hospitals is done in all of the hospitals. Everything is very structured to be very uniform throughout the system. Marijuana is legal in Colorado. It's not legal in a lot of other places. And so this is likely managed differently. And that's likely where that, mandate for the drug tox screen comes in.
I just had a quick question, Lisa.
Yeah, that's helpful.
Oh, sorry, Kayla.
Oh,
I was
no,
just
I was
gonna
just going to
ask-
say, I think, especially if we're thinking about trying to push this conversation backwards into the prenatal, backwards in time, right? Not in progress, into the prenatal care time period. I think for those of you who see folks prior to labor and delivery, I think it's worth us just considering before requesting, if somebody reports substance use, then I think there really isn't much more that we need to know on that day from their urine that's different than what they've reported. And there's just much lower false positives from self-report than there would be from urine testing. And so keeping that in mind, I think in the labor and delivery and birth hospitalization, when infants' care is being impacted at that moment too, that's a different consideration, but just for what that's worth.
Amen.
I was just gonna ask Lisa, when you're bringing up the topic of when they give the screening tools, it then hits your protocol for them doing the urine tox screen. And I was just thinking, do you think that when the staff are giving those screening tools, do you think they're going at it with the attitude or perspective of assisting the patient, the purpose of the screening tool to be assisting the patient by getting them more resources and help, or do you think it's more to catch them in a way? Because I think that attitude change we've been talking about in the Learning Collaborative can really impact the patient's health outcomes.
Yeah, no, I don't, we're all nurses, are just lovely people. And I don't think our nurses at all want to, punish someone. I think that it's not a terribly comfortable subject for anyone to talk about. And they sort of want to just get through that and have that part be done, because then they want to, help the patient enjoy their birth experience. That is also something that I think each of us can really work on, even individually, one-to-one. Changing the lingo on the unit from addict to substance use disorder, changing the mindset about, a person is using drugs as opposed to why they're using drugs, what other experiences, led them to a place where that felt like the right thing to them. And so I'm trying to, every day, just bring that dialogue to the hospital now that I've been able to learn this all from you guys, and, try to pay that forward.
So Lisa, this is Cindy from Swedish. We're working on the same thing you are, which is, how do we make people feel safe, non-judgmental, reduce implicit bias, and make them not feel threatened when we ask them these questions. And so we did we provided an expert training to the nurses and the providers with good attendance from the provider side, but we only got 4 nurses. But trying to provide education to the nurses on how to talk to these patients and make them feel safe, and we're taking care of you and the baby and all that, is to maybe provide education on your unit on expert in some way, shape, or form. And that's what we're working on right now.
Yeah, definitely.
Yeah.
Well, I definitely think, you know, oh, Kevin says he's happy to provide additional expert trainings to anyone. I think what comes into play here too is, of course, like how the screenings are introduced, like we're saying. And one thing that could be a great PDSA cycle is trying out a script that you use to introduce the screenings. And we have a script already in the team resources folder that I will link for you. But what we're actually going to be doing, we discussed this yesterday on our expert faculty group meeting, which is the group that sort of a bunch of different people who sort of guides the content and sort of strategy of the Learning Collaborative. And one thing we talked about doing yesterday is working as a group, as that expert faculty group, to update this script, and I just put it in the chat, to make sure it has feedback from patients with lived experience who can tell us, you know, is this the best way to introduce something? And just get some more eyes on it to make sure that the messaging is really honed. And then this is definitely something that would make for a great PDSA cycle of like, let's try out using a script. Obviously not word for word, but just like, you know, familiarize yourself with the script and sort of try to present the screening in that way. And then, you know, do the PDSA cycle around it. Are we getting more consents? Are the conversations going better on sort of different measures? You know, like, does the patient seem more willing to talk? Are they seeming more comfortable? Things like that. So I think that'll be really important for sort of tackling this issue, and hopefully we'll make it even more patient-centered. And with that, Kelly, if you could launch the evaluation poll. I know we're a minute over. Please, 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 if you can, take a second to do the evaluation poll before you leave. That would really help us improve. And I think this has been an awesome discussion. As always, I'll send out the resources we discussed today. So I'll send out Dr. Wymore's slides. I'll send out what Elena shared, and I'll send out this script. And we really appreciate your time and the discussion here. We will stay on for a couple of minutes so people can complete that evaluation. Please do. It's very helpful to us. And also, we're happy to stay on if people have more questions or more to discuss. But we know we're a couple of minutes over our allotted time. So feel free to jump off after you complete the evaluation poll.